invite Dr. Nagarajan sir, HOD of Department of Medicine from Satya Sai Medical College to chair the next session. Luigi Gnudi, Professor of Diabetes and Metabolic Medicine from London, and he is a clinician, teacher and researcher on diabetes and its chronic cardiovascular complication with specific interest on diabetic nephropathy. He would be talking on diabetic nephropathy and its recent advances in pathophysiology and management. Sir would be joining us online.
Good morning or good afternoon there. I would like, first of all, thanks the organizing committee for this invitation. I'm Dr. Luigi Gnudi. I work at Guy's Hospital in London, at King's College, London. And I'm here to discuss a few points on diabetic kidney disease, a little bit on pathophysiology and many of the main management today that we implement with patients to delay the progression of this devastating chronic vascular complication of diabetes. Today, I will discuss a few points, something that I covered in the past this meeting, discuss briefly, very briefly, as you heard this already, on the presentation of phenotype of diabetic kidney disease, and also then move on treatment and what are really the highlight of treatment from the past to today for the treatment of this chronic complication of diabetes. So first of all, this is well known to most of you, is a recommendation from Great Kitigo from 2020, but this has been confirmed also in recent year, and guidelines on diabetes management and chronic kidney disease. And you see as the chronic kidney disease at different sort of stages. From the left, as GFR declines, we have different stages, worsening being stage 5 with the GFR less than 15. And of course, this is followed by a different stage of albuminuria, from normal to macroalbuminuria, A1, A2, and A3 respectively. And you see how the combination combine. The message here to take is when I see a kidney disease with macroproteinuria, usually the GFR, the destiny of the kidney is poor and we have a rapid decline in GFR. But what I would like also to discuss with you today, that we are seeing different phenotypes also in patients with declining GFR, but no albuminuria. We'll get into that a little bit later. So here we are. So we have a classical presentation that we see mainly in type 1 diabetes, as we know when it starts, with an initial hyperfiltration and progressive renal decline, and occurs on macro to macroproteinuria. And as I just was mentioning to you, mainly in type 2, we observe patients with no proteinuria but decline in GFR. This is slightly a different disease with macroangiopathy, insulin resistance, severe insulin resistance, dyslipidemia, and this affects mainly the glomerular compartment, also tubular compartment, and it's really quite different. So certainly the treatment that we're applying is the same to controlling diabetes, dyslipidemia, hypertension, etc., but it's quite different. And then we have a third group, which is sort of taking its pace as we are better in diagnosing diabetic kidney disease. But when you see a rapid GFR decline in your patients, and for example, you have a good glycemic control, a good blood pressure control, good lipids, and a good lifestyle, you always have to think of maybe some other parallel kidney disease, such as IgA nephropathy. We've seen a lot of HIV nephropathy, membranous nephropathy, diseases that are not driven by diabetes, but sometimes are present with the damage with diabetes, so mixed presentation. So remember, a normal decline of diabetic kidney disease, we are happy if we have a loss of GFR of about 1 to 2 ml per minute per year, but when this becomes 3 to 5 ml per year, that's quite rapid and brings the patient on a dialysis setting, which we don't want, renal replacement therapy. So we need to think about many other different things and what can be present in concomitant with diabetes, and so we can treat it and help the patient. One note, so this is a paper of 2014, and the data goes back in 1990 to 2010, and is about the trend in age standardized rate of diabetes-related complication among patients in the US. And you see, so on the left is diabetes, on the right is patient without diabetes. You see that really for MI, stroke, amputation, we really had an impact. And this is driven mainly by the introduction in the 90s of inhibition of the renin-angiotensin system, statics and statin, etc. But you see, we don't have much impact on end-stage renal disease. The same is for the population without diabetes. So that's really more marked on the left in patients with diabetes. Clearly, maybe patients survive more, so we have more patients not dying and reaching the stage of dialysis. That could be a reason. But also, we had clearly a little bit of impact on end stage, I think, from the data we have in terms of incidence, but the prevalence is still really very, very high because of the number of patients. And there is a clear, as we know, interaction, and this is very important to remember, between the kidney and the heart. It's a sort of cardiorenal syndrome type 5, which with diabetes that damages both the kidney, and we're focusing on that today, but also the heart. And there's a lot of interaction. A kidney that fails affects the heart for the occurrence of anemia, for the uremia, and different other parameters, and vice versa. So these two organs do sort of behave similarly in terms of pathophysiology. They talk one to each other. They're very interrelated one to each other. And clearly, when we treat the kidney or we treat the heart, we have both of them. And there is a strict correlation, as you see from this, is a seminal paper by going in New England, and it's presented in this paper here, but where we see that the age standardized rate of death from any cause or cardiovascular event and hospitalization for A, B, and C, as renal function declines from more than 60 ml per minute to less than 15, let's focus on panel A, you see a dramatic increase in death. So the more your renal function declines, the higher your risk of dying. And this is a link which is very, very, very strict. And so kidney really, really important in the management of survival in patients. But what are the treatments? What are the principles? Well, we win by preventing damage to the kidney. We win by preventing damage to the heart. But let's focus on the kidney. So there is data from the DCCT, type 1 diabetes. This is the only study that clearly tells us we control like diabetes, we control glycemic control, we prevent kidney disease, and we delay the progression and the renal function decline. Of course, together with the glycemic control, lipid control is very important, and of magnitude importance is blood pressure control. This is key because the glomerulopathy in diabetes is related by the significant hemodynamic perturbation. In diabetes, as you see on the right, this is a glomerular with the afferent and efferent arterioles. There is an increase in local potassium angiotensin 2. There is activation of the renin-angiotensin system, and there is an unbalanced constriction of the afferent and efferent arterioles, with more of efferent arterioles constriction compared to the afferent, resulting in glomerular hypertension. Further, at the level of the proximal tubule, there is an upregulation in diabetes of the SGLT2 inhibitor, which reabsorbs sodium and glucose. And so there is less sodium presented at the macular dense, and this results in a vasodilation of the afferent arteriole. All this contributes to the glomerular hypertension. So glycemic control, lipid control, blood pressure control, lifestyle measure, of course, control of weight, overweight, obesity, stop smoking, balanced diet, etc. Now, in the past, there were a lot of discussion about how do we inhibit the renin-angiotensin systems. And we had ACE inhibitors, we have angiotensin II receptor blocker, and there was a lot of belief that probably a double blockade of the system could benefit the kidney. Many studies conducted in type 1 and type 2 diabetes gave sort of discordant results. But I would like to present you a study really that sort of told us a lot. And this is enough from this study. In this study was conducted in patients with type 2 diabetes with estimated glomerular filtration rate between 30 and 90 ml per minute, and increased urinary albumin excretion rate, so albuminuria. Now, these patients were all treated with losartan, and there were two groups, and in one group was added lisinopril, the ACE inhibitor, lisinopril or placebo. And the study was stopped early because of side effects of this combination and for hyperkalemia and kidney injury. And here I show some of the image. Here is the primary and the secondary endpoint, and you see the two lines on the right are basically overlapping, so no benefit clearly in terms of fall in GFR or albuminuria or death, very important endpoint. In the combination between losartan and lisinopril versus losartan alone, so ACE and ARB combination versus ARB alone. And here I show you the side effect profile, in which you see there was indeed a significant increase in acute kidney injury in the combination group, losartan and lisinopril, and of hyperkalemia. This clearly tells us we have to be careful. We have no benefit, and we have issue with safety. And this is to bring you to a more recent study. It was a study of firenone. Firenone is a new non-steroidal selective mineralocorticoid receptor antagonist, which was claimed not to have that important effect in terms of hyperkalemia. Again, the study population type 2 diabetes with proteinuria with different range of GFR, which you see here. And the results of the study were encouraging compared to the nephron study. So all these patients were treated with ACE or ARB, and the two group was placebo versus addition of firenone, this mineralocorticoid receptor antagonist. So this study was positive. There was a lower risk of chronic kidney disease in the firenone group, but again, and this is shown in these slides, so firenone better in terms of renal outcome, and we're speaking about, importantly, a sustained decrease of 40% in eGFR, which means a doubling of creatinine. But again, we see hyperkalemia, which was double in the firenone group compared in the placebo group. So the difference with the nephron from this study here is that we have a benefit in terms of renal outcome, but we still have hyperkalemia. So it's probably a matter of selecting the patients that we, and possibly if we're really desperate, if we want to confer an extra protection in terms of kidney disease, we need to implement treatment with resins or potassium binder that prevent the hyperkalemia. A little step ahead, but still we have some issue with safety in this population. So the side effect not as bad as we saw with ACE inhibitor and ARB, but possibly some more work to do, and we have to select our patient better in a way. And of course, now I'm coming to the SGLT2 inhibitors. I won't cover all the study, but this is a study with dapagliflozin. And why I'm bringing this study, because in this study, there was a study of patients with diabetes, patients without diabetes, and the kidney benefit, the renal protective effect was seen in both patients with diabetes and without diabetes. And that tells us something very important. The effect of the SGLT2 inhibitor, which we know with very good renal, with a good kidney, act also as hypoglycemic agents, is not driven by an improvement in diabetes control. Also, the effect is very quick, and we know that glycemic control effect really takes a long time to impact the development and progression of complication. So it's probably a hemodynamic effect. The bottom line is that we really don't know how they work and what's the main driver, and many hypotheses have been proposed. I would like you to live with this little scheme. If you remember, I was discussing before the importance of hemodynamic impact in the pathophysiology of diabetic kidney disease, in particular diabetes glomerulopathy. So if we use, from the top, if we use inhibition of SGLT2, we inhibit the reabsorption of glucose and sodium, so more sodium at the level of the back of the veins by tubular glomerular feedback will cause an afferent vasoconstriction and protection of the increased hemodynamics in the glomerular capillary. If we block the RAS, the renin angiotensin system, we correct the imbalance of vasoconstriction efferent more than the afferent. And if we use the two drugs together, which we are doing today, we probably combine these two protective mechanisms. That's why the two effects are additive. That's why SGLT2 confer an extra protection in patients treated with renin angiotensin 2 inhibitor. So a great drug finally to protect patients with kidney disease. But we had another surprise recently, and this is reflected on the GLP-1 receptor agonist that we use for the treatment of diabetes. Different mechanisms proposing a protective effect on diabetic kidney disease, both hemodynamic, probably sodium balance, but not linked with the SGLT2 transporter, anti-inflammatory, improvement of insulin resistance. And recently we have the award 2 trial against in patients with type 2 diabetes and severe chronic kidney disease on standard treatment. And this is, we have once a week dulaglutide in this study, a starting HbA1c of 78%. There is a drop of about 1% in this population. And here you see 2 doses, 0.75, 1.5 of the dulaglutide, and the control arm was treated with Lantus. And you see at equivalent glycemic control, there was an important delay following GFR in the patient treated with dulaglutide. So GLP-1 analog, again, like SGLT2 inhibitors, an important tool that we now have to protect the patient in the kidney disease. Note, and I want to recap to what I was saying at the beginning. When we treat the kidney, we treat the heart, and indeed both SGLT2 inhibitors and GLP-1 analogs confer a significant cardio protection in our patients. So clearly important drug to use for cardiorenal protection. And here we have the final little summary. So we have our 3 phenotype, the classical diabetic kidney disease, they combined with our glomerulopathy, and the third on the right is the falling GFR without albuminuria. And clearly, these drugs, as they work also in patients without diabetic kidney disease, can be utilized outside diabetes, especially the SGLT2 inhibitors. That's where we have data for cardio protection. So really, I would say that SGLT2 inhibitor and GLP-1 reflect the impact that the RAS inhibition had in the 90s. And this is a summary of my story. So renal lesion can present slightly different phenotype. Watch out for rapid decline of GFR. Albuminuria can or cannot be present. So a typical presentation. And be careful to non-diabetic renal disease that can be on top of diabetic kidney disease, and the treatment as been discussed in RAS. Double blocker with ferrinon, be careful with hyperkalemia, consider in choosing your patient, and SGLT2 and inhibitors and GLP-1 agonists, and statin, of course, for the parallel drug. And I finish here. Thank you for your attention, and see you soon. Bye-bye.
Thank you, sir. Due to some inconvenience, sir could not join us online. And we have our next speaker, Dr. Jambanathan Ramanathan, MD Diplomat, American Board of Internal Medicine, diplomat in American Board of Infectious Disease, faculty in Department of Medicine. He would be talking on strategies for reducing hospital redemption for heart failure patients. Sir, join us online.
Hello, good morning to all of you. This is Dr. Ramanathan from Roy, Michigan, and glad to be presenting in the